And so, as has been pointed out in the talk during the lunch break, the FDA, and was mentioned just a moment ago, the FDA has allowed us to have a surrogate histologic endpoint to get early accelerated approval for MASH therapies while we wait for the outcome studies. And that is MASH resolution with no worsening of liver fibrosis, or fibrosis improvement with no worsening of steatohepatitis. And if you have both, that's even better. So resmetirom is the first therapy that has met that bar of the 52-week histologic endpoint. Now, as was mentioned a little bit earlier, I'll just go over resmetirom for a moment. It's a selective thyroid hormone receptor-beta agonist. It's liver targeted with none of the, or limited number of the thyroid hormone alpha effects. So that's the tachycardia and the bone loss you think about when you think about thyrotoxicosis. How does it work? It enters the hepatocyte and it acts like a thyromimetic. And it turns on a number of downstream pathways. One of the most important pathways is improving mitochondrial function. And it does that by two mechanisms. One, it promotes mitochondrial biogenesis, so the replenishment of new, fresh mitochondria, but also promotes mitophagy, which is a normal process in the cell to clear tired organelles. So by getting rid of the tired organelles and replenishing with new, it essentially it's improved the fat burning factory. And so by increasing the ability to oxidize those lipotoxic intermediates, you have less lipotoxicity, downstream ER stress, oxidative stress, ultimately reduced stellate cell activation. It also increases the expression of LDL receptors on hepatocytes. And that's why you see a reduction in LDL in response to this therapy. And as we heard earlier, the number one cause of death in these patients, particularly in the earlier stages of the disease, is cardiovascular. So having a drug that also has positive cardiovascular potential benefits is important. So the burden of kind of clinical trial data that led to the FDA approval includes 4 phase 3 clinical trials. The first is MAESTRO-NAFLD, which was a safety and tolerability study that went on for 52 weeks. It included 1,200 patients. Of those patients, approximately 700 went on into an open label study to continue to gather safety and tolerability data. MAESTRO-NASH is the registrational trial, which was the 52-week biopsy study and is continually ongoing to look at those outcomes, the liver, the kind of hard clinical outcomes, which ultimately we have to see for a therapy. And the MAESTRO-NASH outcome study, which is currently ongoing. This includes patients with compensated cirrhosis, and we're looking for decompensating events. So over 1,500 patients receiving the top dose of 100 milligrams and over 2,000 patients receiving the 80 milligrams support the accelerated approval. So this is data from the New England Journal of Medicine paper. So patients were enriched with cardiometabolic risk factors. They were given either placebo, resmetirom 80, or resmetirom 100 milligrams, 50-week biopsy, and we continue to follow them for liver-related outcomes. You can see that there's an increase in the NASH resolution. You can see 38% versus, I don't have my glasses on, so I'm like, is that close enough? Compared to 10% in placebo and 26% in fibrosis improvement by one stage compared to 14% in placebo. And when you look at those that either improved or didn't change, and that's important. In this disease, stability is a thing, right? If you freeze somebody at F2 fibrosis for the rest of their life, they won't die of liver disease. So you really want to look at stability or improvement. And approximately over 80% of patients on resmetirom improved or remained stable. When you look at the reduction in lipid by MRI, PDFF, or CAP, you can see this decrease by both throughout the course of the treatment in those that received 80 or 100 milligrams compared to placebo. In terms of key secondary outcomes, there was a statistically significant reduction in LDL, as well as other atherogenic lipids and liver enzymes. So those patients who have elevated baseline liver enzymes, you see a reduction in AST, ALT, and GGT. In terms of adverse events, if you look at the top line, those that had at least one adverse event was pretty equal across the three arms. But as we heard earlier, diarrhea and nausea were more common in the resmetirom treatment group compared to those in placebo. Generally occurs within the first 2 weeks and generally resolves by 4 weeks. Now, we don't want to use this right now in patients with cirrhosis. We don't have enough data on either safety or efficacy, and the clinical trial is ongoing. The label is for advanced, moderate to severe advanced fibrosis, F2 and F3. So at this point, we want to make sure that we are not giving patients with cirrhosis this therapy. We want to rule out other causes of liver disease. I think that goes without saying. And importantly, you want to rule out autoimmune hepatitis by checking autoantibodies, immunoglobulins, and when in doubt, you want to do a liver biopsy. I'll just make note that one patient that was talked about that had the high liver enzymes, they actually had autoimmune hepatitis. There is a gallbladder-related adverse reaction. It was very small numbers, but it is on the label. In terms of concomitant drugs, you heard this earlier, you don't want to use it with gemfibrozol or cyclosporin. If your patient is on a clopidogrel or Plavix, you kind of do a 20 milligram dose reduction. So if you started at 80 milligrams, you go to 60. If you started at 100, you go to 80. In terms of statin use, as I mentioned, resmetirom does lower lipid panel, and it's recommended that you limit the daily dosage of rosuvastatin and simvastatin to 20 milligrams and pravastatin and atorvastatin to 40 milligrams because there could be increased statin exposure. In the clinical trial, 95% of patients were in these doses. So dose adjustment is not that common, but it's important to be aware of, and other statins are fine. So it's only these 4 statins that are called out. So this is kind of a consensus. This is going to be published in CGH soon. It might have some slight adjustments from this, but an expert panel got together because the FDA didn't really provide much guidance. It was very ambiguous, kind of consistent with F2 and F3 fibrosis. So a group of us got together to try to bring some recommendations that people can use. So this is kind of like the Goldilocks slide. So in green, when you choose the patients who are perfect candidates for this therapy, VCTE between 10 and 15, and you saw in the Maestro-NASH trial, the median KPA was 12. So this is kind of getting that sweet spot. If you have access to MRE between 3.3 and 4.2, ELF score between 9.2 and 10.4, that is exactly the IQR that was in the Maestro-NASH study. If you want to use FAST, you can use MAST, you can use MEFib if those are things that you're comfortable with. But importantly, there cannot be any evidence of portal hypertension. So doesn't matter what your NIT says, if you have splenomegaly, you have evidence of collaterals, your platelets are less than 140, you don't want to be treating this patient. Now, those that you want to consider for treatment are those that have a VCT between 15 and 20, an MRE between 4.3 and 4.9, an ELF score between 10.5 and 11.3, the same FAST greater than 0.67, MAST greater than 0.24, and MEFib positivity or negativity is fine. But again, no evidence of portal hypertension. And then you do not treat those with a VCT greater than 20, MRE greater than 5, or ELF greater than 11.3, because those are pretty good rule-ins, as we saw in the previous slide, for cirrhosis. So this is our recommendation for monitoring. Again, there might be slight adjustments, but I'll at least make the key point, is that if you identify the appropriate patient for therapy, At your 3-month mark, you're really just looking at tolerability, making sure they don't have significant side effects. In the study, some patients had a little blip in the first 4 weeks, which normalized. So this really wasn't a DILI event. There hadn't been any significant DILI events from the 2,000 patients in the study. And so really at 3 months, you're just kind of doing a check-in. You're not really assessing efficacy. It's too early. At 6 months, you can start to again think about efficacy, but really at 12 months, you want to see improvement or stability in PDFF, VCTE, or ALT. I will say that if you have access to PDFF, those that had a greater than 30% reduction in PDFF, that was the greatest predictor for histologic efficacy, but not everybody has access to that, and CAP is not that quantitative. You want to see, obviously, a reduction, but it's hard to make significant decisions on that. You want to think about stopping therapy, of course, if there's intolerability or evidence of another liver disease. But if you see 2 NITs increasing or worsening over this time period, you might want to consider stopping therapy.